fever, nausea, vomiting, decreasing or absent bowel tones, and can be a precipitant septic shock. Peritonitis can happen in a number of settings. Anytime there's any pathology which involves the abdomen, keep peritonitis in the back of your mind. And whenever you get a shock from peritonitis, it is particularly deadly. All right, jumping on to slide 2 is a little cartoon infographic about manifestations, risk factors, things like that. And looking over at the risk factors, perforation. Remember perforation. Whenever you have a patient who has a penetrating wound, a stab wound, a gunshot wound, or kind of like we talked about last week with the patient who undergoes a colonoscopy, that can be a risk for perforation. Those abdominal contents can spill out into that peritoneal cavity and cause a pretty substantial infection and could lead to peritonitis. Under the diagnostics, it can be a little innocuous when this is starting up. And I say that because a patient who has an ongoing abdominal issue, which would place them at risk for peritonitis, could also have symptoms leading up to this that may be mimic or are going to cover the symptoms of peritonitis. And I say, as an example, I see a ton of patients in the ICU who have been very immobile for a long time. They're getting a lot of medications and or pain medications that will severely slow their gastric motility down. And when we look at their abdomen, it can be very very firm and taut. But I want you to keep in your mind board-like. Board-like abdomen is a lot different than an abdomen that's firm. It's very hard. It's almost a little unsettling when it happens because something is very weird. Jump to the next slide. So those are things I want you to know there. So in this little infographic here, it kind of talks about some of the symptoms you're going to see. Increased pulse, BP, dehydration, pain, and decreased bowel tones. And like I said, a lot of these patients that are going to be at risk for this are already going to be exhibiting some of these symptoms, especially the ones who have penetrating abdominal trauma. They're probably already going to be a little tachycardic. Their BP is going to be a little up with pain. Their bowel tones are going to be down from immobility. So it's you have to pay a very close eye to these patients to try and figure out that this is happening. Now, I'll say one of the key features that you're going to see here in peritonitis, because this indicates that some sort of inflammatory and or infectious process is going on, is that they will be febrile. So remember that. Patients will have a fever typically. Board-like abdomen, fever. So diagnostic testing, CBC, looking for any form of leukocytosis, any other signs of infection on the CBC, abdominal x-rays. We're going to look to see if there's some sort of process we can easily identify. Now, when it comes to an issue like this may or may not be able to be seen on x-ray. When you're dealing with tissues of similar densities in a space, if it's a overt infectious process that's causing this, you may not necessarily see it. You may need a CT of the abdomen and pelvis. Blood cultures as well. If this is a systemic infection, we want to speciate what may be in the blood. And for the x-rays, sometimes you'll be able to see differences in air fluid levels, meaning that there may be some sort of, especially in the setting of perforation and or something like an anastomotic leak, when different parts of the bowel are sewn together. Air can get into the abdominal cavity, and you'll be able to see that on chest X-ray or abdominal X-ray. Therapies for peritonitis, obviously these patients are going to be NPO straight away. We're going to give them IV fluids because their nutrition's impaired. NG tube dissection, now that's going to be a maybe, and I say that just because NG tube dissection was an automatic knee-jerk reaction that we've done for a lot of years, and the one thing that I've seen in clinical practice is that we tend to try to avoid it if we can because we don't want to disturb their acid-base balance too much. That being said, if these patients are extremely, distended, they have this board-like abdomen, then chances are we're going to go ahead and put them on suction. Oxygen for shock, if these patients are starting to look shocky, which they often do, you want to give them supplemental oxygen to try and help with tissue perfusion, take a little bit of stress off the body. Antibiotics to treat the underlying cause because we can't fix this unless we fix what's causing it. Analgesics for pain, this can be very painful. And there's, depending on the physician that you might work with, they have differing opinions on analgesic management for these patients because they're very concerned about worsening their gastric motility or causing anything to get worse by that way. So that is something to keep in mind. Paracentesis, which is a needle aspiration if there is a fluid buildup in there that's causing this. And surgery, including peritoneal lavage. Now this one, put a star next to this one. This is something that is typically a go-to therapy for these patients, and they tend to have multiples. And sometimes if it's bad enough, they may leave the abdomen open. They pack it with either a suction device or a wet dry dressing, and then every other day, or every other day, they'll go back to the OR and get it washed out if the infection's bad enough. Or if they have a leak from either bile or stool, or in the case of certain issues with the pancreas, they can have a constant leak into their abdominal cavity and need several washouts. Possible complications, septic shock, adhesions, which we spoke about last week, and that happens when those, when we disrupt anything in the abdomen, and especially for somebody who has to have multiple surgeries, they'll start building up this scar tissue within the abdominal cavity, which can be extremely problematic later in life. And then abscesses, of course, which are kind of as a secondary injury mechanism from the primary source of infection. So let's go into chronic inflammatory bowel disease, IBD. So this one's things get a little nuanced when you start looking at things like IBD, IBS, diverticulosis, diverticulitis. So we're going to try and look at the key features so we know more what to focus on. So in this case, you have an inflammation of the bowel. It can be acute, it can be chronic. I've seen clinically I've seen individuals who have one really bad flare-up and end up getting a partial colectomy, and it never happens again. And then you see people who have this chronic form of it, where they have, almost this constant diarrhea, which can be aggravated by stress, emotional events, and it can be extremely, extremely severe. And then every couple of years, they're getting a piece of colon taken out or a piece of bowel taken out as this begins to eat up pieces of the bowel. Now, these patients, I want you to make a note of this, they are at a higher risk for colon cancer. You have chronic inflammation in the bowel, and that puts you at risk. And remember, we discussed this a little bit last week, chronic inflammation anywhere puts you at a higher risk for developing cancer in that setting. So similar to smoking we discussed, when you have this constant irritant, similar to what we discussed last week with upper GI cancers. If you have like even something like GERD, alcohol intake, these constant irritants are going to put you at a higher risk for cancer in just about any setting that they're in. IBD is typically not brought on by stress, but stress will exacerbate it, just as a note. Environmental triggers being infectious in nature. A lot of times if these patients are coming in with an acute exacerbation, they're going to go on antibiotics straight away to try and help their bowel. Has a strong genetic component, 20 to 40% link if there's family history of. And it is most frequently seen in the Jewish population. Jump to the next slide. Differences, location, and pathology. So now we're going to break it down into Crohn's and ulcerative colitis as these kind of subtypes. Crohn's is any portion of the GI tract, but usually in the distal ileum and ascending colon, and can extend through all layers of the bowel wall. That's important to note from a diagnostic standpoint. So whenever you see these patients coming in, they're often going to get a CT of the abdomen, and what they look for is that thickening of the wall of the colon, and it can be very pronounced. Now, ulcerative colitis typically involves the colon and the rectum, with rare involvement into the distal ileum, and it affects superficial mucosa. Now, with these two, Crohn's typically requires lifelong management, and I've seen patients where they have one incidence and it's labeled as Crohn's, which leads one to think that maybe that isn't the case, but it is medically labeled as Crohn's, and they have an intervention and then they go home and never have another event. But typically true Crohn's is a lifelong, requires lifelong management. So Crohn's causes ulcers, weeping, and weeping in the swollen intestine. And even though we've identified the areas which are typically involved, it can involve any portion of GI tract. So you want to remember that. Crohn's disease, again, it's this chronic process, so it can cause fistulas, abscesses to form, scar tissue to form, narrowing of the intestinal lumens. It does damage over time, even outside of acute flares. If scar tissue begins to form, it goes back to what we discussed about adhesions. They can really start to hinder the transport of the gastric contents through the bowel. Jumping back down to ulcerative colitis, it's again an inflammation in the colon and rectum. Now, ulcerative colitis is in the name. It causes multiple ulcerations. Remember that. Ulcerations. Edema and sloughing of the mucosa. So this tends to be infectious, and is often connected to Pseudomonas or other viral infections, and its incidence is twice that of Crohn's. So when you're seeing one of these patients, you want to think, what is the most likely culprit that I'm dealing with? Which, when you're talking again about GI issues, you're really going to have to take a good history, physical, and assessment to try and assess what's going on. There are some potential complications, which I'll tie them to these, but they'll tie to just about anything that happens in the bowel. One of them is perforation, which we discussed. Anytime there's a chronic process which can do pretty substantial damage to the wall of the colon, you can perforate, and that is a bad setup. You can also develop toxic megacolon, and this is something we'll talk about a little bit later. And then you can also have massive hemorrhages. Whenever there is damage to the stomach, the colon, the small bowel, that area requires a lot of blood. So if there's damage there, then you can bleed out a lot and quickly. So here we have a picture of some inflamed bowel. You can see in segment B, you have a kind of a nice smooth bowel, and then in segment A, you have some very inflamed bowel with some yellow patches there. That looks like some sloughing within the bowel. Oh, that's a toilet. I'm gonna try past this. And here's another photo with a healthy colon in here, and then an ulcerative colon. You can see it is extremely red, inflamed. This is not happy colon. So jumping down to nursing assessment, predominant symptom, diarrhea, and usually bloody. I would say clinically that once it becomes bloody, that's when they're in the hospital. If they have, if they have this known history and they're having all this diarrhea, a lot of times they'll try and manage at home, but folks who are dealing with this long term know their body fairly well. And once it gets to a certain point, we hope they show up before it becomes bloody. Because at that point things become very painful, and we have to give them a lot of fluids. We sometimes have to give them blood and antibiotics to get this to settle down. Crampy abdominal pain, more in the right lower quadrant with Crohn's, and left lower quadrant with ulcerative colitis. You can think about the etiology of those diseases when we were talking about the pathophys a little bit. Intermittent low-grade fevers, abdominal tenderness, hyperactive bowel tones, weight loss and/or anorexia, malnutrition and hypoalbuminemia, dehydration and electrolyte imbalances, anemia, especially if they're having this chronic bloody stools, and then perianal abscesses and fistulas. Fissures can develop over time. And as a note, the diarrhea is profound. They can have 10, 15, 20 stools a day. I've cared for patients who, they just opt to sit on the toilet as long as they possibly can, or at the bedside commode. It's pretty awful. Pain is more common after meals. And the decreased albumin, keep in mind that when you're losing this protein and you have this low albumin level, that affects your overall recovery, among other things, including drug transport. So if your patient's albumin gets too low, it can definitely be a talking point with your physician. Diagnostic testing. There's a couple things. You have the barium enemas if we're looking low. You have the proctosigmoidoscopy and the colonoscopy. We tend to use a colonoscopy as a catch-all. They can see a fair amount, and it typically is fairly definitive. Even though it is very invasive, it gives us a lot of information. Stool exam for blood. We can culture the stool. CBC, looking for any signs of infection and general inflammation. An elevated SID rate. So in Crohn's, you can use an X-ray and that may show you evidence of ulceration, but honestly, it's fairly hard to see. Colonoscopies, you can see kind of what we looked at before. You'll see some edema in those tissues. They can look like they're sloughing. They can look very friable. I've seen some very severe cases of this where we have patients who essentially come in, every 2 months or so because their bowel is so inflamed they keep perforating. It's like their bowel is often described as Swiss cheese in extremely severe cases. For from a medical treatment perspective, starting at diet to, as far as prevention goes. Now, diet is a very controversial factor right now. A lot of times, they push towards, no nuts, no seeds, no spicy foods, increasing your fiber, limiting your caffeine, and decreasing gas-forming foods. And you should remember that because they still test you on that. But there is a current body of evidence that suggests that there is no change in frequency based on things like that. And that's something that we'll revisit in diverticulosis as well because of the pouching aspect. But diet is important, and it's important to find what works for the patient as well. Drugs, corticosteroids for inflammation, sulfasalazine, immunosuppression if required, antidiarrheals to slow things down, antispasmodics, and or anything at surgery. We're going to look at drugs separately, but I'll note some of our anti-inflammatory drugs, such as sulfasalazine, you need to take with a full glass of water. Remember that. Take it with a full glass of water. That way you can decrease the risk of kidney damage. And for immunosuppressants, mercaptopurine. Remember that. We'll go over it later when we go through the farm slide. Bulking agents and the antidiarrheals, so that may be Metamucil. Also using loperamide to decrease gastric motility. Loperamide is something that we want to use with caution if we have a patient whom, and this is why when someone has very profound diarrhea, let's say they don't have a known history of this. Sometimes we're a little slow to say use something that decreases motility because diarrhea is one of your body's way of getting rid of toxins. So if there is, when you've had bad food or something like that, and you have all this diarrhea, what you don't want is to keep that inside because then you can get really sick. But with patients who have known IBD, loperamide is an option. There we go. Okay. Jumping down for surgical treatment. Surgical treatment does not cure it. I think of it as a temporizing measure. It can be considered a cure for ulcerative colitis, though. You can have a segmental colectomy.
Hey, Ryan.
Hey.
Sorry to interrupt you. We have a question from Catherine.
Okay.
Sorry, what was the immunosuppressor you mentioned?
That is mercaptopurine.
Thank you.
Thank you.
You have one. All right, back to surgical treatments. Like you said, not a cure for Crohn's, but can be curative for ulcerative colitis. We were talking about the segmental colectomy with anastomoses. Segmental colectomy essentially is just a partial colectomy, a partial resection of the colon with an anastomosis, which is a joint of those two pieces. And they may be given a colostomy as well. Now, this can range from the segmental colectomy all the way to a total colectomy with a permanent ileostomy. You can also have an internal ileal reservoir and an ileoanal reservoir. So, Crohn's disease, at least 50% of Crohn's patients need one surgery, and 20 to 40% of them have a recurrence within 5 years. In ulcerative colitis, about 25% of these patients need to have surgery, usually when medical management fails, and that's important for both of these, when medical management fails. So here we have some photos of these colostomies and kind of their position in relationship to the colon. And this is important. You will see these and I'm actually going to draw your attention to the double-barreled colostomy. I've actually seen a few of these. This is often used in emergencies such as intestinal obstruction or perforation, but I have seen these used long-term, and they can be a little jarring. Pre-op checklist. Have you all discussed surgery, like surgery preparation?
Yeah.
Okay. Like a comic book. All right, nursing diagnoses. Diarrhea related to inflammatory processes and constipation related to narrowing of the colon. Again, down here you can see where it says fruits, vegetables, wheat, grain, bread. Again, remember that. Remember that. But remember that whenever you're managing these patients, you should ask them what works for them. Those who are actively managing their disease and are having some success in that will typically know. I'm gonna jump past these. Break time. 10 minutes.
Okay.